Yeah, it's okay. Thank you everyone for coming back after lunch. A super lunch, I hope you agree. Lots of chatting and lots of networking, and great morning, I hope you would agree. And we've got the first of our sessions for the afternoon session. I don't need to introduce myself, as you all know me now. And what I'm going to probably do is just ask each speaker once they get up just to say a few words about themselves. So that's being a lazy chair, isn't it? But yeah, I'm just going to invite you up to say what you want to say about yourselves. So this afternoon is a little bit more about the so what. So we really want to start thinking about practice policy. What are the implications of some of the work that we're doing? So we're going to get two of our collaboratives to be talking a little bit about some of the learnings of their work. They're not presenting studies, but it's bits of work that they've been doing, which is trying to inform the future and how we engage with the public, etc., etc. And then we've got two other quite different talks for us to learn from. So our first speaker of the afternoon is Duleep Allirajah, and Duleep is going to start off the afternoon. And all I'm going to say is that please, you may, if you wish to sit at your seat, if you wish to stand at the lectern, you can do, or if you want to dance, you can do whatever you want to wake people up. It's from the Richmond group, and I think you will explain to us all about the Richmond group, but a fantastic group of charities. Thank you.
Thanks, Mon. Yeah, so I'm Duleep Allirajah. I'm Chief Executive of the Richmond Group, and we are a coalition of 14 national health charities. We mainly work in the kind of policy influencing space, and our strategic focus is around multiple long-term conditions. So I'm going to talk a little bit about our work to date, and then have a look at where we think researchers should focus their efforts in order to drive change in policy and practice. So a little bit of history. 2018, the Richmond Group set up something called the Task Force on Multiple Conditions. And it was a partnership with the Royal College of GPs and Guy's and St Thomas's charity. It was a 3-year program, and what the program really focused on was what was perceived to be a gap in the research on the lived experience of multiple long-term conditions. So we published a couple of ethnographic research studies, and through our research and through talking to people living with long-term conditions, we kept hearing the same themes, the same problems. So people told us that their care was fragmented, that the story didn't travel with the patient. They told us about the admin work of being a patient, otherwise known in jargon as the treatment burden. They told us that it was overwhelming, that they had unmet social needs, their quality of life was impacted, so their mobility, their social connectivity, all impacted by their kind of health state. So through our work, we didn't just kind of look at what the problems were. We tried to identify some of the solutions. So I think we've got a fairly good idea about the ingredients of what good care looks like. And if you have a look at our multiple conditions guidebook, that's one of the reports we published, which outlines what good looks like. So I'll rattle through this because I want to kind of make sure there's time for discussion. So good care is proactive. It means the system doesn't just respond to crisis, but it anticipates and prevents crisis. Good care is coordinated. It means that the agencies and the professionals involved in someone's care talk to each other rather than leaving it up to patients to do the joining up. It's minimally disruptive. This is a phrase coined by or used by Victor Montori from the Mayo Clinic to describe care that minimizes the administrative burden that falls on patients and their carers. It's patient-centered, so you start with the question, what matters to you? And it addresses someone's needs in the round, so not just their clinical needs, but the non-clinical problems that adversely impact on their health. So our focus in the last couple of years, so the task force wrapped up in around the start of the pandemic, and in the last couple of years, we've very much pivoted towards trying to, from articulating the problem, to try to influence policymakers and system leaders to do something about the problem. So last year we published our manifesto called 1 in 4. It's a manifesto for multiple conditions. So we understand that obviously changing a complex system, it can be a bit like boiling the ocean. It isn't quick, it isn't easy. But what we have tried to do with the manifesto is to set out some really simple, tangible things that system leaders and government can do to help drive and accelerate the redesign of care for people with multiple conditions. So firstly, that means leadership and direction setting. It means ensuring that the policy levers support joined up care, and often they actually work in completely the opposite way. So those of you who know QoF in primary care will know what I mean. It fragments care rather than joins it up. And it also means providing local systems with the tools and resources to redesign care. So we know there's some really good pockets of good practice, particularly in the field of geriatric care, anticipatory care models or proactive care models, but these are very much isolated examples. So I think there's a really important role here for national bodies to spread the learning from these care models and provide local system leaders with the know-how, with the change management support, with the tools, the resources to redesign care for in their geographical footprints. And I think it does need a policy team. I disagree with the idea that it's everyone's responsibility. I do think there's a risk there that it becomes nobody's responsibility. So I'm getting the 1 minute sign. What I want to look at next is how the research community can contribute to changing policy and practice. I think there's the big gap, and I've alluded to it, is that there's not enough evaluation or intervention studies that we need an evidence base basically for the models of care that we need to put in place to join up care. So I'm just going to quickly look at the issue of disease clusters, and I'm not going to talk through this slide because it will take too long. But I think I think there's a really important problem here, which is that the more you study clusters in isolation, it limits what you can tell us, right? If you're looking at disease clusters in a very biomedical way, it obviously informs the development of prevention strategies, of drug treatment, and so on, and screening. What it doesn't tell us is it's not so good as a predictor of risk or of healthcare utilization. So I think you need to look at other factors when trying to do risk prediction. There's a really important need to develop case finding or risk stratification tools to identify people who are most at risk of entering hospital. I think that what the research tells us, in a few studies that have looked at clusters, it tells us that there's a huge heterogeneity of clusters. And if you only look at clusters in their isolation, you don't get the full picture. Right, I'm getting the red card now. So what does this mean? I think it means we need to widen the lens. We need to look at social factors. We need to look at behavioural factors if we want to inform policy. And I think that for people, we should also be looking at clusters of impact, not just diseases themselves. So fatigue, pain, breathlessness, low mood, those are all things that are common to a range of diseases. So there's different ways in to looking at this problem. If you just look at disease clusters, you don't get the full picture. So to conclude, I don't know if there's a card after red, but I'm in the injury time here, trying to sum up. I think we're at a particularly important moment in time with the new government and a health secretary who has said in the health mission that Labour published before the election that they will be putting in place care coordinators for people with complex multimorbidities. So there's a hook there, right? And I think what we need to do is work out, well, what does that mean? What are the care models that need to sit around it outside of hospital? And I think the research community has a really important role to play here, because we don't have a strong enough evidence base for what works. And I think that's, I mean, I'm not saying stop what you're doing and change course, but we need a lot more research that's on the, to inform the interventions and the care models that are going to really transform lives for people with multiple conditions. So thank you for listening.
Thank you, Duleep. And for somebody who loves their football, you're now banned for 3 matches. Okay, so that's so feeds in very nicely to some work that one of our collaboratives have been doing, which is looking, we haven't discussed this very much, but not just looking at medical needs, but also social needs. So it's my great pleasure to introduce Hajira, who will take on the next spot. Thank you very much indeed.
So thank you for inviting me. So I'm Hajira, I'm a GP. I'm leading the Cluster AIM program. I'm very excited to share with you a little bit about what we've been doing in the Cluster AIM study. I'm not going to present lots of results, but just really give you a flavor for why we should all be thinking about social care in the context of multimorbidity. I'm going to start off with just a case study of one of my patients. This is a patient who I've looked after for a number of years, and she was diagnosed with rheumatoid arthritis probably 5 years ago. And because of the number of flares that she has and her reduced mobility, she's lost her job as a cleaner. And she's now at home most of the time. She put on a lot of weight. She developed type 2 diabetes. She's gone into depression. She lives on the 5th floor of a council house that has no elevator, so she can't get downstairs. I often come to see her and she's not been to the shops for weeks. She hasn't got fresh fruit, fresh vegetables. She often doesn't collect her medication. English is not her first language. So there's been a real problem with communication with the pharmacy about who's going to drop the medicine, who's going to collect the medicine. And the council has put her on a list. She's waiting to move houses, and that's taking God knows how long. And I go out to see her every sort of couple of months or so to do a review. And most of my consultation is focused on dealing with the social context. It's not, she doesn't really prioritize taking her atorvastatin or her metformin because she's trying to survive and she wants to eat and she's worried about the fact that she's lonely and she's not seeing her family. And this patient exemplifies why when we study multiple long-term conditions, we cannot be focused on the biological factors alone, on the clinical factors alone. We have to think about the social context. And that's really what the Cluster AIM study is about. That's the challenge that we set out to achieve as part of our program. We wanted to understand from big databases whether we can quantify social care, understand it in some of the existing databases, and then develop clusters that consider both the social context and the clinical parameters. And it's been pretty challenging. We started off with this working definition of social care that I'd like to read to you. It's really thinking about the individual needs in assisting them with their daily activities of daily living, maintaining their independence, enabling them to play a full part of society, helping them in vulnerable situations, managing complex relationships, and making sure that they are supported with their accommodation needs. And it's very important to highlight that it's not just about an individual's social needs, it's about their ability to participate in the wider society in which we live in. And what we set out to do was sort of a multi-step process of trying to look at the literature, look at the existing codes, look at what's been done, and then ask the patients to what extent do the existing codes and linked social care data really match up to what we think is important in the non-biological parameters of social care need. And we carried out multiple steps, so I don't have time to go through, but please do read all of our papers. We did a very extensive qualitative package. I wanted to put a big picture of Dr. Glenn Simpson because he leads a lot of this in my team and he's brilliant. And he interviewed people right the way across multiple long-term conditions to really understand what matters to people living with and caring for multiple long-term conditions that's not the biological parameters. And we did a Delphi prioritization exercise to try and work out what are the most important factors. And we mapped out each item in existing databases, linked new databases, created new codes, and we came up with 8 different categories of social care need. And you can have a look at sort of each of them. Activities of daily living, mobility, finances, disability, community care needs, particularly voluntary sector contributions. We looked at their residential status, their social network, being lonely, being isolated, and experiences of bereavement. So bereavement was an interesting one that came out from our patient interviews, and not one I'd really considered in multimorbidity context as a GP. But interesting, a lot of our data shows if someone is widowed or bereaved, your likelihood of developing multiple long-term conditions is hugely increased. And we applied a lot of these codes to CPRD and to SAIL. We used Aurum and Gold. And what we found, the key thing was that 40% of people with multiple long-term condition had a social care need that was not being met. And what's particularly worrying is we're likely to be underestimating this. The data is problematic, as all the AIM consortiums will know. There's missing data, there's incomplete data, the codes are not used. So this is probably a much bigger problem than we understand. And as far as I'm concerned, I've not come across any interventions in GP that consider both social care alongside clinical need, and that's where we have to go next. Just to give you a flavor for the type of unmet needs in England and Wales from our data, the biggest one to highlight was community care needs. I think that the whole of the NHS underestimates the relative contribution of voluntary sector and charity sectors in dealing with social care need, and that's something that we have to talk more about. I've talked about missing data, the fact that I think this is a huge underestimation. And then this is a slide I stole from our health economists. I'm probably going to get in trouble for showing it to you because this is a paper that they're still working on, but they started to estimate the cost of some of these needs per year. And you can see it's £34 million per year for our sample for personal care needs, 51 million for community needs, 34 million for social needs, and 277 million when it comes to residential needs that are unmet. And this is a really important slide when it comes to impact and trying to understand that this costs money. And if we're going to develop clusters, we should be thinking about how we're going to deal with the social needs alongside. The next step, so we are coming to the end of our projects. It ends in June next year. And we've got a couple of extra grants now, program development RFPB, and we are developing interventions that we're hoping to take to trial next year, which will identify social care and multimorbidity risk and try to curb that trajectory over time. Thank you for listening, and this is the whole team.